Just want to check with OrthoTV. We are ready. Okay, right. Yeah.
Yeah,
So
you can.
It will be channel now, is it? From your side also? Ramesh, when you say okay, I will start. Okay, yeah.
Yes, sir. Yes. Full screen, sir.
Can you see the screen?
Yeah, yeah. Just you can play, sir. Yeah.
Is it okay? We will start.
Yeah. So you can start, sir. Time up.
Yeah. First of all, I would like to thank everyone for helping me to organize this meeting. This is especially for undergraduates, postgraduates, and also for consultants who want to discuss about the most common fracture that we come across in our practice, intertrochanteric fracture. And the focus is going to be on only one topic so that we'll have a deep discussion about it. That's the whole theme about this one. And we thought of choosing intertrochanteric fracture this time, and I was little hesitant to call Mr. Martyn Parker. There we called as Mr. Martyn Parker because once they finish FRC, they called as Mr. Martyn Parker to see whether he will be willing to join us or not. And he showed his willingness. I'm very happy that he joined us. I will introduce about him when his talk is going to be. It's going to be in next 20 minutes time. He will be giving his talk. And he is a legend on this. And some of the people from UK might know him very well because without his name in the UK, nobody will know about hip fracture. That kind of such a legend. Let's start about the intertrochanteric fracture overview now. Thanks to Alembic for organizing this because they have helped us to organize the meeting and also to telecast it. And thank you OrthoTV for telecasting our program in your OrthoTV channel. So let me start with intertrochanteric fracture and overview. So we all just want to clarify that we are only going to talk about the fractures occurring in this region, which is an intertrochanteric fracture. It's an extracapsular fracture and where the blood supply is well preserved. We are not going to talk about the intracapsular fracture here. So it's going to be a very specific meeting. And here the fixation is the preferred option and most of the time and not the replacement. But in some exceptional scenarios, then we have to think about doing replacement also. So the debate, what I'm going to tell about is mainly about what is the plan of management, how we are going to make decision. And then Mr. Parker's speak will be more about focusing on the management in depth about it. So when you come across an X-ray of hip fracture or intertrochanteric fracture, what are the things that you will see and how we'll make a decision about it? The first thing is a fracture line, whether it's intertrochanteric and is it displaced or not, or is it comminuted. So these are the two things that we want to see. And the next thing is whether greater trochanter is involved or lesser trochanter is involved. The greater trochanter means it's not just bone, it's attachment of the abductor muscles. You have to think in that fashion rather than just thinking it as a bone. And whether the lateral wall is involved or not, and is it a reverse oblique kind of pattern or a subtrochanteric extension. But this is what we want to know because the treatment pattern is going to be either an extramedullary fixation like a sliding hip screw or an intramedullary fixation like a cephalomedullary nail. And totally depends on what the fracture configuration is. So if you see the classification of IT fracture, there are several classifications, but the basic concept will rely on only these 5 statements that I told you, like all these 5 things: fracture line, comminution, greater trochanter, lesser trochanter involvement, lateral wall involvement, and subtrochanteric extension or reversibility. So if you see the events classification where from 1 and 2 are stable variants where you have an undisplaced fracture with the lesser trochanter, displaced fracture with the lesser trochanter comminution, GT, LT, and comminuted trochanteric fracture and the reverse oblique. So this is Evans classification. Similarly, Kyle classification look in a similar way with factors involving lateral wall, greater trochanter, lesser trochanter, comminution. So and similarly, Boyd and Griffith classification is exactly similar to that also. And if you see the AO classification or OTA classification, there again, same like 3 is the name of the bone, which is femur. 1 is the proximal aspect of the femur, and A is the intertrochanteric area, where A1 is greater trochanter avulsion, A12 is intertrochanteric fracture is undisplaced. One with a medial fragment or a lesser trochanter fragment is A13, and more than one fragment, which is multifragmented, is forms in a A2, 2 and 2, 3, and 3 is forming like a subtrochanteric reverse oblique type of fractures. Similarly, AO classification also exactly comes in the same way, but the whole pattern exactly is like where the fracture line, how many fragments are there, GTLT is involved or not, lateral wall is involved or not, and whether it's a reverse oblique pattern. And the treatment pattern is going to be extramedullary fixation like a dynamic screw for more the first scenarios where there is multiple things like subtrochanteric extension, you're going to cephalomedullary nail. So this is what that picture I have put it for you. So typically a fracture displaces in the same fashion only, which shows the pull of the muscles. So a proximal fragment will go up like greater trochanter is being pulled by abductors, and iliopsoas is pulling the lesser trochanter, so it always gets pulled medially. And distal fragment goes up due to hip flexors and pull of adductors. That distal fragment gets pulled proximally. So this will be the typical scenario in most of the fractures. So now, and you will see clinically patients have a shortened, external rotated and varus displacement. And varus displacement is a very cynic scenario, which is the one which we need to correct it all the time. And I'm just going to show some case examples and how you can make decisions about it and what are the factors that you involve in making the decision. So first is, I want to show a very simple fracture. A 72-year-old man has fallen and has got a simple fall and has got a fracture over the trochanteric region, where you can see a simple IT fracture in a Evans classification forms the type 1, Kyle classification forms the type 1, here the 31A1, 2, and here the first type of the OA classification. So this one is a very stable fracture. For this, only thing that we want to make sure we don't want to displace the fracture while we are fixing it. So for example, there is a neck shaft angle for all the hip joints. And our neck shaft angle for a DHS screw is 135 degree or 130 degree or 140 degree fixture angle, 135 degree that we keep. While fixing these fracture, we can in fact displace the fracture also. That is what we have to make sure. And fixation like a dynamic hip screw will do an excellent job, and the patient will not have any problem. They will heal without any problem. This is a very basic type of fracture. Here, there is no lateral combination, there is no GT involvement, there is no LT involvement. It's a simple IT fracture. Now, what is DHS is basically, it works in the principle of that you have to put your lag screw exactly 90 degree to the fracture line. Then only that sliding mechanism works very well. It's got a short barrel and a long barrel. The barrel length is about 25 mm or 38 mm, and it comes in about 135 degree angle. Barrel and plate angle is about 135 degree, and the lag screw is about 8 millimeter in diameter. The thread length diameter is about 12.5 mm. So this is exact principle how it works. And sliding hip screw, the point I emphasize is that the fracture size should be exactly 90 degree to the lag screw. Otherwise, it will not slide. It might go into failure. The concept will be, which you will know it in further slides, like when you come to the reverse obliquity or a subtrochanteric fracture. But now take this fracture. This is not a strictly IT fracture, but it comes into the intertrochanteric region, and it goes proximally to the, we see that it goes to the intracapsular area. This is the one we call it basicervical fracture, and it's a 15-year-old girl who had fallen down and sustained this fracture. In a younger patient like this, we definitely don't want to go and do replacement. We want to do fixation. If you are fixing this type of fracture, there is a chance that when you are fixing it, this head can rotate in, so you have to put a derotation screw intact. So this is another ideal one situation for doing a sliding hip screw. So now look at this one, where you have a fracture which is detected only in the MRI scan. The patient came with a fall and pain in the trochanter region. MRI showed a GT fracture. X-ray showed a small evidence of GT fracture, but MRI confirmed the GT fracture is extending to the trochanteric area and also to the lesser trochanter also. So we want to go and fix it. But the patient wanted a mini incisions. Specifically, he told that I want a very small incision. So I thought I will do the cephalomedullary nail for this. And cephalomedullary nail, even the DHS will do exactly perfect job for this condition without any problem. And the studies have shown DHS and PFN will not have any outcome different. But the only advantage for this is a mini invasive, minimal blood loss, and quick surgery also. For this, I have done PFN, except just for the patient request only. Otherwise, I would have done DHS for this particular patient. And similarly, in this kind of scenario where we can debate on whether you can do a DHS or PFN, we are doing PFN only for the reason that it's a mini invasive where you are doing with a 3 small incision, you can perform the procedure, you can finish the procedure in smaller time also. The DHS also can be done in half an hour to 1 hour maximum. And the same time duration can be done with the PFN also. But the biomechanical advantage behind the DHS and the PFN is you can see that the DHS works on a principle of long lever arm, but the intramedullary nail will have a short lever arm. So it is acting like a load sharing device. This is a load bearing device. So the chances of failure is slightly less in comparison to the DHS for the PFN. This only applies to those. In the biomechanical setting, it applies to that, but clinical setting has not shown different in these kind of fractures where it's a stable IT fracture with where you can get very good reduction. So now we go into the gamma nails. I think we evolved from 1988 to now. Current generation is almost, we have come to 4th generation nail. This is a gamma 3 is a 3rd generation nail, where initially the valgus angle they kept is around 10 degrees. Now we are keeping only around 4 degrees, and the screw has been proximalized so that to prevent the fracture. So this is the evolution of the proximal femoral nails. And now what we are having is the 4th generation nail or a 3rd generation nail, where we are able to have a 13.5 mm proximal reaming, and the latch screw where you can actually put a locking screw over the slot here. And the distal screw is actually, you can do a dynamic slot, and also the distal tip will be about 5 to 8 centimeter, much more distal than the screw side, so that it will avoid the fracture also. These are the modifications happen, and the fracture incidence has become much low. Initially, when I remember in 90s, we were used to do the gamma nail, and it was had a bad time, the time showing that it is developing fracture at the distal area. And that has been substantiated by after having the gamma 3, where the distal fracture has been reduced almost 0.5 to 1% now. So look at this scenario where this patient has got a fracture pattern which is like Evans 2 or a Kyle 2 and 3-1A-1-3 or a OTA classification like A21. Here you have a stable fracture with IT. There's an IT line and also a reciprocantal line in a 76-year-old with fall and hip pain, and where I have done nailing. Here the important thing is about that you have to get your screw position exactly right position. If the screw position is wrong, even this fracture, a good fracture may also fail. We don't put the nail correctly. Here there is no lateral wall combination, but see, this may be a good candidate for DHS also. And also in the same time, and both will have a similar outcome. We see this patient who has got a 4-part fracture, greater trochanter, lesser trochanter, and you have IT fragment also, but the lateral wall is not involved. Lateral wall is no combination there. So this may be a candidate for a DHS. If the lateral wall combination is not there, then DHS will be a very good indication for that, and they will slide in very well, and you can make sure that latch screw goes almost 90 degrees to the fracture side, and the fracture will slide and it will give a good outcome at the end of the patient. Now look at this scenario. This patient who is 72-year-old had a fall and has got this fracture, where you can see a fracture line over the GT, LT, and the shaft is broken, and fracture pattern is also not like exactly 90 degrees that will go into from IT area. There is a combination there also, where it forms like a Evans 3 or a Kyle 3 fracture. And these are the fractures. There is lateral wall involvement. If there is lateral wall involvement, then the DHS should not be a good implant. Then what you have to do is you have to go in for a cephalomedullary nail, like where you have to do a proximal femoral fixation. As you can see there, in this case, there is a small distraction. Not distraction really, it's about a 1 centimeter gap at the fracture side. But if you make the patient weight bear, this X-ray was taken on 7 March 21. This X-ray was taken on 10th April 21, which is about a 1 month gap where the patient has been mobilized with weight bearing. And you can see that fracture has collapsed to come to the almost near full approximation. That is an advantage of all these sliding mechanism, where if you make the patient to weight bear, then actually this will help the fracture to slide to a comfortable position so that the fracture will come and unite in a nice way. This is the advantage of having all this. And here also you have to make sure your lag screw goes exactly about 90 degrees to the fracture so that the sliding mechanism will work. So this one, if you see the next one, this fracture, sorry for this picture where it shows a lot of grains in that. This fracture is, it has got a GT and it's going from almost from intertrochanteric to subtrochanteric. It's a pretty nasty one. This patient actually even did not have a pain. I was also looking for, could it be a pathological? The pathological is just because it is just a classification or the highest end of the AOTA classification and Biden-Griffith type 4 classification. Some of the fractures you can't fit into the classification also because they doesn't exactly fit into the same morphology as a description. This one, there is no option other than just doing a nail. There's no point in DHS. DHS will not work for this because it is a IT with subtrochanteric extension, and additional advantage can be gained by putting a circular wire to hold the fragments together, because adding a circular wire to the fixation will increase the biomechanical strength of fixation significantly to help for the patient to mobilize sooner also. But this patient has got a guarded mobilization now with partial weight bearing, and she is only about not even 1 month since had the fracture, and she had a fixation done recently. So if you look at this one now, this lady, 83-year-old lady, who has got a fracture pattern, something like Evans 4 or Kyle 3. Here LT is involved, GT is in multiple pieces, and IT is not fragmented. Intertrochanteric line is still there, but GT is fragmented, LT is fragmented, but the lateral wall combination is not there. This also you can think about doing a DHS, as you can see, or a DHS, or even you can do a PFN also. But DHS also work very well because I did PFN mainly for the reason for doing a biomechanical advantage and also for the incision sake, where I do a PFN. But DHS is also a good implant for this. And if you look at this one, this is kind of, people can call it as subtrochanteric pattern, or it's almost like a reverse oblique. But if you see the fracture line, it's going in this fashion. So if we are going to put a DHS in this kind of scenario, so this is a scenario where the DHS is absolutely contraindicated. If you do DHS for this kind of patient, you are going to end up with a failure of the fracture healing and also failure of the implant also. I'll show an example later on for this. This patient had a double fracture. If you can see that the fracture is over the distal femur and also in the proximal femur. It's like a segmental fracture. So we did a nail. It's a very tricky procedure because if you have to do a for this one, you will compromise the distal femur fixation. In the same time, you can also change the place where the screw is going in by even if you can't make even 5 mm error in this kind of patients. You have to be pretty accurate. You have to make a preoperative templating and make sure you are putting the right length of the nail. Here we have not done the open reduction at all. We have done through the close manipulation and done fully through close technique with the help of the C-arm. And this patient came for follow-up today, and we saw that already early calluses started forming there, so which is good sign. So next thing is 40. For this, you see this 40-year-old lady who has got polio, affected on the left side only, and has got fall and sustained this fracture. This is a really difficult fracture. If you see this fracture, it is like not just subtrochanteric; it is going like into the trochanteric area, and the proximal fragment is fully gone up. It is like in Boyd classification, comes under grade 4, and other classifications may not fit in at all. And these are the fractures which is very challenging because in a polio individual, the diameter of the medullary canal is going to be very small, and you cannot think about doing a nail for this one because the nail diameter minimum that we have is around 9 mm, and this lady's canal diameter is only about 8 mm only. So we have to opt for the DHS only. So what you have to make sure is that you have to make sure the lag screw is in the center, and you manage to get your valgus reduction. And here what I have done is I have done like some osteotomy of the fracture site and made to sit on the shaft of the femur, so that you try to make sure it is totally in the valgus position. So this patient is now almost like 9 months since the fracture, and she is already healed up now. You can see it is healed up in the valgus position, and there is no margin of error in this kind of case. You have to make sure that you put the center lax screw and make sure you are not putting in varus position. If you put in varus position, it will not heal, it will fail. Look at this scenario. Here this patient has got a multi-part trochanteric, multi-part lesser trochanter, and IT is also very bad. Here there is no option for doing a DHS, only option you have to go for a nail. The key thing is you have to make sure the reduction is perfect. The reduction is not good, this treatment will fail. The reduction is the key factor in all these patients. Very important that you have to do reduction correctly. So look at this one, a 75-year-old gentleman who had a fall, but is almost 3 weeks or more than 3 weeks since he had an injury. And here the bone quality is too bad, almost like the previous fracture like this one. But this is you can see that this is 3.5 weeks old, and the fracture is more comminuted, IT fragment is comminuted, lesser trochanter is comminuted. The only option for this kind of patient is not like fixation. You have to go for replacement. Here I have done replacement for this. You have to put a long stem and do replacement. But here the important thing is you have to fix the GT to the shaft. Here what we can't see it there, but what it is, we have used a fiber tape to fix it. Or you can use a circular wire to fix it also, because it's a very comminuted greater trochanter fracture, like almost in the 7 or 10 pieces there. I've used a fiber tape to fix it, and he is almost now more than 6 months down the line since he had it, and he is doing comfortably fine. So these are the few case scenarios. But what should not be accepted is a gross varus reduction. As you can see in this particular patient who was referred to me from Par area, that after 9 months after fixation, he had the failure of this implant because of non-union. As you can see, this fracture was fixed in varus. Almost 95 degree, the angle is there, next shaft angle is, and anything that you do fixation in a varus, then it's doomed to fail. And I had to revise this to, after doing osteotomy and doing grafting, and I put it as a nail, and then the patient went well. And a similar thing, anyone getting infection, this patient had an infection after a simple, it was not a bad fixation, it was a good fixation only when I did the surgery. After within 3 weeks time, she came like this, where you can see that the lax screw is falling apart, and the wound was having some infection also. So I had to exercise her, and then she was not willing for any surgery at all. He just said, leave it alone. And by nature can do sometimes miracle. As you can see that she is now almost 2.5 years down the line. She is able to walk without any problem. She is almost like Gerdelson procedure, where you have done this excision of implant and the head is still there, but she is able to walk, and she is happy as it is. So sometimes you can remember that in the worst scenario, sometimes nature can do miracles also. You can leave a Gerdelson also, can sometimes do a reasonable job, and the patient can be happy patient also. So what we have to know is that you have to know all the armamentariums of the management on all these patients. And the outcome depends on, for the intertrochanteric fracture, is fracture pattern. No implant, however strong, can sustain the undue forces. If the reduction is not good, your fracture is not going to succeed very well. The outcome is not going to be very good. And the fixation technique, whatever technique you do, your lax screw, the Cleveland has mentioned 9 zones, out of which the center and inferior center are the best one in the AP and lateral view. If you have managed to put that in those zones, the chances of you having a failure is little low. So you have to have a good fracture reduction, and also you should have the optimal fixation technique. Then the ultimate dictation is done by the bone quality. So that's what we need to know. To summarize, intertrochanteric fractures are very common. Fixation strategy depends on fracture configuration. Reduction of fracture is most important for success. Varus reduction is never acceptable. So now try to achieve at least the angle of about 130 degrees. If you're not able to achieve that, then it's going to fail. Then you have to use adjustment measures to get the reduction possibly correct. Outcome is so dictated by fracture pattern, fixation technique, and bone quality. Thank you very much. I think if there are any questions, we'll take it now. I think Sugavanam has joined. Welcome, Sugavanam. Sugavanam is one of the UK returned surgeon who is practicing in a nearby city called Salem, and is one of the prominent orthoplasty surgeon and hip fracture surgeon also. He has joined the meeting also. So if there are no other questions for now, I think we'll go to Mr. Martyn Parker's talk.
Yeah, yes, sir.
I have a privilege to introduce Mr. Martyn Parker to our whole group of audience here and also to the OrthoTV, that he is the eminent senior most consultant in Peterborough District Hospital in the United Kingdom. He is known to be pioneer in managing hip fractures. To my knowledge, he has written more than 200 articles about hip fracture. I know that he has written book on hip fracture management, and also he has been written guidelines for National Institute of Clinical Excellence in UK and Scottish Intercollegiate Network, and also for other policymakers. He forms a prominent and popular person for managing hip fractures, and I am very pleased and feel thankful to welcome Mr. Martyn Parker for our program. And if you are ready, Martyn, you can start sharing your screen and please give your speech. Thank you.
Thank you very much for inviting me and for speaking. Can I just check? Can you see my slides coming up there now?
Martyn, sir, just give me a minute. I just want to change one setting. 1 minute, sir. Yes. Martyn, sir, you can unmute. Yes. Martyn, sir, you can. Yes, I have asked you to unmute, sir.
Dr. Martyn, please unmute yourself, please.
Sorry, yes, it got muted again.
Yeah, fine. Yeah. So you can share your screen, sir.
Yeah. How's that? Can you see that okay with my slides?
Yes, sir. Perfect, sir. Perfect. Yeah.
Perfect. Good. And you can hear me okay? Okay. So I'm just talking therefore about trochanteric fractures, really. First of all, a little bit on terminology and classification of these fractures. And basically, that is trochanteric area there. It used to be termed per-trochanteric, which means between or through the trochanters, but it's quite confusing, and so we're tending to move that to trochanteric. Basal fractures, two-part fractures running along the intertrochanteric line, and these used to be termed intertrochanteric, which is between the trochanters rather than through the trochanters, but have also been termed transtrochanteric. So it's quite confusing a little bit of the terminology, but tending to say those in the blue area trochanteric, and then those at the level of the lesser trochanter, transtrochanteric or A3 on the AO classification. And then your subtrochanteric fractures are those that are located 5 centimeters of the bone distal to the lower border of the lesser trochanter. We classify these, and there's various methods of doing it. Jensen was a modification of the Boyle and Griffin classification into 5 types on the AO, and then more recently the AO classification. But all of these classifications have been shown to be unreliable if we're trying to communicate between each other, apart from the more basic classifications such as that used by the AOs, the A1, A2, and A3s. So what the recommended classification, therefore, is to use stable trochanteric. Hello? Can you hear me all right?
Sir.
Carry on. Good. Yep. Stable trochanteric are two-part fractures there, maybe displaced or undisplaced, also termed A1 on the AO classification. Unstable trochanteric fractures. These are 3 or 4-part fractures with the fracture line running between the trochanters and lesser or both or greater trochanter coming off. And then your A3 fractures, which are reverse or transverse fracture lines at the level of the lesser trochanter. How are we going to manage these fractures? Well, we can treat them conservatively, and these here listed are the indications for conservative treatment. But in the UK, it's very, very rare indeed to treat one of these conservatively. We've got our anaesthetists willing to anaesthetise all the patients now. We've got the appropriate facilities and implants, appropriate trained surgeons, and we always try and talk our patients into it. So treating these conservatively is very rare in the UK now. We'd operate on all our trochanteric fractures if possible. Surgical issues, really, we've got 3 surgical particular issues to consider: how to reduce the fracture, which implant we put in, and then how we put that implant in. And the fracture reduction and the surgical technique are the most important parts rather than the choice of the implant. So first of all, fracture reduction. And we can either leave the fracture in a varus position, anatomical, or a slight valgus position, slightly over-reducing the fracture. And we measure the fracture reduction, varus or valgus, by the Garden Alignment Index, which is normally 160 degrees for anatomical, less than 160 would be varus, and more than 160 is a valgus reduction. Other people use the femoral neck angle as shown in the top there. The normal is around 130 degrees for a femoral neck angle. So you can use either, but the Garden Alignment Index is the most commonly used, measuring from the trabeculae in the femoral head against the shaft of the femur. So this is an example of what we should not be doing, a varus reduction. It's basically the fracture has not been adequately reduced, not enough traction has been wound onto the fracture table, and therefore the lag screw's gone in as low as possible, but it still remains high in the femoral head. And this is biomechanical unstable, it's a poor fixation, and all that happens is the fracture will tilt a little bit more into varus and then cut out occurs. And so this is not how to do it, it's a very poor technique. Trabeculae angle here, 140 degrees. Normal anatomical is 160. So that's a varus reduction. This is more how to do it. It's slightly over extreme, really. Valgus reduction, trabeculae angle has been up to 170 or so degrees here now. The fracture line has opened up a little medially here, you can see, and the lag screw is easy to position now. Perhaps a slightly extreme example of it. But as the patient weight bears and mobilizes, this rapidly consolidates, the fracture collapses a little bit, and it soon fills in with callus and heals. So this is the valgus reduction. And even if you're doing a nail, it's still exactly the same. You want a slight valgus reduction for these, opening up the fracture just a little bit medially so you can get a good screw position. So nails and sliding hip screws are exactly the same for your reduction on the AP. Reduction on the lateral view, on the axial view, essentially you want to get everything in a nice straight line, the femoral shaft, trochanteric region, femoral neck and head, all in a straight line, 180 degrees as defined by Garden Alignment Index. And then you can put your implant right down the middle. And the same applies for a nail or a sliding hip screw. This is how not to have a reduction on the lateral. And you sometimes see this on the more comminuted fractures or on the larger obese patients where the fracture is displaced into this angulated position, dog leg position you might hear. And here's the fracture's unreduced. The lag screw's gone in as best as able, but this bit of cortical bone here has forced it to go posterior. And posterior is really bad because all that happens is that the proximal fragment will rotate 90 degrees, posterior is superior, and it'll rapidly cut out. That's guaranteed to fail. That fixation is there and should not happen. So that's an angle of 110 degrees. You're looking for 180 degrees on the lateral. How should you be reducing these fractures? Well, generally, we're going to do a close reduction using the fracture table, and I would always use the fracture table for these and not try it without, reducing it to the slight valgus position. Occasionally, you can't get it quite as you want, and some of this is displacement in the lateral view, and you might need to lift it up a little bit using a bone lever placed underneath the femur, or maybe a pointed object here onto the proximal side of it to try and push that bit down. So maybe you might need to push that down, lift the other one up here to try and get that alignment corrected there. So you can do some limited open reduction, but failing that, you might have to do a more formal open reduction of it. This is a posterior reduction device that you can put onto your fracture table, and it's useful in these fractures here that are sagging, as shown on the X-ray there. Put in the posterior reduction device to try and lift up the femur and reduce it into a more acceptable position. So that's your fracture reduction. What sort of implant are we going to put in? And we've got lots of implants available for these fractures, but essentially it's choice between a nail or a sliding hip screw these days. Now, I'm the author of the Cochrane Review, where we've looked at all the randomized trials that have compared nails versus sliding hip screws. And we've got a very good evidence base on this over the years. So far, 44 randomized trials have been reported on this topic. This is just an example of stuff that we would take from the Cochrane Review. So here we are, we're comparing nails versus the sliding hip screws. And I've added up the failure rate for the nails coming down here on the left side, and then on the right-hand side, the sliding hip screw. And if we look at those studies all before 2000, then the results are all showing an increased failure rate for the nails. And here's the summary of the results here on there. So certainly before 2000, the nails were not doing as well as the sliding hip screw. But over the years, the nails have been modified through the different versions, have all been improved. It was particularly problems with nail breakage and fracturing around the tip of the nail. So over the years, things have improved, and the randomized trials that are coming out listed, and here's those after 2000, showing gradual improvement. So now we've got equivalent failure rates between the sliding hip screw and the nails. And even if you begin to look a little bit more down the bottom here, it's moving over, favouring the nails a little bit. Not statistically significant as yet, but it's heading that way. So as the nails keep getting better, and as our surgical technique of putting nails gets in better, and we're beginning to see failure rates getting better for the nails compared to the sliding hip screw. But it certainly wasn't the case in the early days. So this was the early days, doubling the failure rates for the nails, primarily due to breakage of the implant and fracturing around the tip, but now pretty much the same between the two. We can also look at other things within the randomized trials, and we can't find any significant difference for implant cutout, wound healing complications, that's in the early studies. In the later studies, suggestion of slightly lower wound healing complications with the nails. Transfusion rates seem similar, hospital stay, mortality similar, and degree of residual pain for these patients. But the suggestion in the recent studies now that the length of surgery can be definitely reduced for the nails as a quicker operation, and there is suggestion also you get better regain of mobility for those treated with the nail. And the reason is possibly that the fracture is healing in a more anatomical position with less collapse occurring around the fracture side. So we're seeing a tendency towards nails becoming better as the years have gone on. This is the sort of thing that I've been doing. So over the last 15 years or so, I randomized 1,000 patients between a nail and a sliding hip screw, and I consistently was able to show a better regain of mobility for those treated by the nail using a blinded observer. So it was all not open to bias. No difference in the mortality, fixation, failure rates, reoperation, or residual pain, but just better regain of mobility for those treated with the nail. And also the nail was a slightly quicker operation. So there are certain difficult fracture patterns, and as I mentioned, really, these can be quite challenging, really. And the sort of difficult fracture patterns you begin to worry about are those that the reversed, the A3 level fractures at the level of the lesser trochanter with a transverse or reversed fracture line, or also those ones shown on the right here, we're seeing more often these days in the severely osteoporotics who've just fallen over and the whole trochanteric area is just completely disintegrated into nothing, really. You try and think, where is the lesser, where is the greater trochanter in that X-ray on the right? And they've all just disappeared. So we see this fracture a little bit more now, and a short horizontally lying fracture on their proximal fragment. So how we should be treating these more difficult ones? Well, the problem is that the femur in these difficult fracture patterns can be pulled medially by the adductors, as shown here in this X-ray here. And so the fracture position allows it to come off medially. And this is bad, really, when we get medial displacement of the fracture. If you're treating it with a sliding hip screw, then your lag screw will go straight in and around the fracture site, and it can all get a bit difficult as things go on. We can measure femoral medialization using this simple method here, the ratio of A over B, and roughly you can estimate the degree of fixation failure will increase as your medialization increases. So if you've got 50% medialization, a 50% failure rate, and by the time you've got to 100% medialization, it's pretty much guaranteed your fixation will fail. So medialization is something we don't want. And you can use a sliding hip screw here, and on the left there is one of these fractures fixed with a sliding hip screw. Medialization of around 50% has occurred. There's been a lot of slide of that lag screw there. A short barrel was used, as we would normally do. If the lag screw goes straight in at the fracture site, it'll measure 80 millimeters or less. In that case, you've got to use the short barrel plate to increase the amount of slide you've got. Otherwise, you've not got enough slide to let this collapse. The fracture's collapsed. I've also put the compression screw in just to prevent the barrel becoming separate from the lag screw, as can occur with the short barrel plates, but not necessarily compression. So the fracture's healed. You've got to get perfect fixation of this, good screw position on the AP and lateral, middle on the AP and lateral, and the fracture is healed, albeit with a fair degree of collapse. So your alternative for this sort of fracture pattern is to put a nail in. And the advantage of the nail is the big proximal portion of the nail will abut against the fragment here and resist medialization here. And also, you can make it dynamic if you want and get fracture collapse occurring across the fracture site longitudinally. So you've got a double sliding action here and here to allow a little bit more collapse to occur and the fracture to heal. So the suggestion is certainly for these fractures that we'd be better treated with a nail. And here's such an example, really, of a reversed fracture line treated with a nail, but showing you can still get medialization regardless of the fact that you're doing the nail, but you'll get less than if you were to use a sliding hip screw. And here's an example of one of these fractures, again treated with a sliding hip screw, medialization occurring, short barrel plate use, but the fracture's healed. There are alternatives. This is a trochanteric stabilizing plate. It's been advocated for these fracture types. It clips onto the side of your sliding hip screw, butts against the greater trochanter fragments, and therefore resists medialization. So it's been advocated and it's been used quite a bit, but not much published about it. Here's an example of it being used for reverse fracture type. You know, the medialization of the femur there. You put on your dynamic hip screw and then you clip on your plate, and medialization is prevented by that plate at the top there going against the greater trochanter. So it all looks very nice on the x-rays, but this patient, it still went and cut out. And maybe it's too rigid a fixation for these fractures. You've got to let them collapse a little bit, but you don't want them to collapse excessively. So as yet, it's of unproven value, the stabilizing plate. Other people have tried to use something like a condylar plate, a 95-degree DCP, or a condylar plate, or a blade plate for these. This is a study looking from the literature, looking at the failure rates for these. Sliding hip screw on this particular fracture, these with the reverse transverse fracture lines, sliding hip screw failure rate in the literature was 7%. Dynamic condylar screw was 17%, and a blade plate 21%. So quite significantly increased from your standard sliding hip screw. And this was a study, again, I did recently in the literature, looking at the randomized trials that have compared for these particular difficult fractures, the A3 fractures, reverse transverse fractures. And on the top here, we're comparing the nails versus a standard, versus a DCP or a fixed nail plate here and looking at the markedly increased failure rate for the plates compared to the nail. So this all looks pretty bad, and we've got a very high failure rate for the fixed ones. And this here is comparing the sliding hip screw versus the nails, pretty much comparable between the two. So 36% failure rate for those fixed 95-degree blade plates, etc., versus a nail. And here the nails versus the sliding hip screw, not a lot of difference. So we can bring to make conclusions really is that these fixed static plates, condylar plates, have no place for the treatment of hip fractures in the primary treatment. But the nails and the sliding hip screws seem to have a similar outcome, but suggesting slightly in favour of the nail, but both can be used. There are other implants you can use, and some of you may have come across an external fixator, a trochanteric external fixator used for hip fractures. And we've now got a number of randomised trials and case series reports suggesting it can be used, but obviously a little bit more time consuming in terms of having to monitor the patients, follow them up and take it off. But the results do seem to be acceptable, and you can put that on a local anaesthetic in selected patients. So we've got some case series reports and randomised trials, but it's still really being evaluated and looked at. And the alternative is you can also put an arthroplasty in for an extracapsular fracture. And we've got quite a number of case series reports of this now and 2 small randomised trials. It does suggest that the functional outcome is pretty much similar between an arthroplasty and a fixation, but the arthroplasty is a much more prolonged operation, a complicated operation with a greater blood loss. So at the moment, it's not recommended for routine treatment, but may have a place in specific fractures occasionally. So insufficient evidence to support its routine use. So summary, what implant you put in for trochanteric fracture, you can use a sliding hip screw or you can use a nail. And by and large, most of them will produce pretty equivalent results, but there is a tendency to slightly better results with the nails and a potential for further improvement with the nails. And if we were to look to the future, then I think the future for these fractures, all of them, would be to treat it by nails. And we're just going through that process at the moment of learning what sort of nail and different nail designs, because there have been some real disasters in the past on these nail designs. Subtrochanteric fractures, just to mention really, you can treat these by a plate or a nail, but obviously there's an increased use of intramedullary nails, if possible with closed reduction and fixation, but be aware this is potentially more difficult surgery with a higher blood loss. But you can use plate, but we're moving away from it these days of using these long plates and fixations as shown here. So preferably for subtrochanteric fractures, a closed reduction. We don't know whether about circulage wise, it certainly does increase the strength of fixation, but then you've got the problem of getting the wire in there. So it can be quite problematic to get in. We don't know whether you're using a reamed or unreamed nail. Reamed nails seems to help the fracture to heal quickly, but it's still not sure. And generally speaking, we'd go for a full weight bearing, even for these big subtrochanteric fractures now. And here's an example of a subtrochanteric fracture treated with a longer nail, but I'll go for immediate weight bearing onto this. How do you assess your quality of your fixation? Well, you're looking for your screw position in the AP X-ray to be central or low in the AP. A trabecular angle, that's the reduction of the fracture around 165 to 170 degree Garden alignment index, and trying to get that screw tip 5 millimeters from the joint. And this is probably a little bit close on this one here, so it's perfectly positioned, but probably just gone in a little bit too close to the joint there. It needs to be around 5 millimeters from the joint. And on the lateral, we're looking to get everything in that nice straight line, the neck, trochanteric region, femoral head and shaft, all in a straight line, trabecular angle 180 degrees, and the screw central, not posterior, not anterior, as central as you can get it, and 5 millimeters from the joint. This is how you can assess your quality of your fixation using the tip to apex distance. So that's the distance between the tip of your lag screw to the apex of the femoral head on the AP and lateral, and add them together. Should be less than the original article said, 25 millimeters. I would say 20 millimeters. And this is the formula to do it. But if you know what your magnification are for your x-rays of your particular system you're using, then you can work it out without having to use this formula every time as to what your optimum should be. But for correction for magnification, the distance is 20 to 25 millimeters. It should be less than. Post-operative care for all extracapsular fractures, I would say it's full weight bearing. We should be able to get them all fully weight bearing, unrestricted mobilization, regardless of how comminuted the fracture was and how osteoporotic. We should be able to get them all fixed up like that. So in summary, the correct treatment for extracapsular hip fracture is early surgical fixation, use a contemporary implant, correct fracture reduction and implant position. And if you do that, you can have unrestricted and immediate mobilization. Thank you, and I'm open to any questions there. Hello? Hello?
Yes, sir. Yes, yeah. Yes, sir. Sir, you're audible.
Yes, I can hear you. Yes, yeah.
Dr. Subramanian, sir. Dr. Subramanian, sir, from your side, there is no audio.
Sir is unmuted, but no. No audio, sir.
Dr. Martyn, sir, there are some questions in the chat box.
Yep. Does the lateral cortical thickness decide the choice of implant? Not really. I have to confess, really, that I nail everything now, because I was doing the randomized trial, nail versus screw, for many years. And after doing that for 15 odd years, we decided I've got to use nail or screws. So the findings were that the nail was better than the screw. So I nail all my trochanterics now, all the two parts and the comminuted and everything. So does it decide the choice of implant? No, because I'm using the nail for everybody. Your worry is that if you're doing a sliding hip screw and you've got a very thin lateral cortex, then that will break as your fracture heals. Then you'll get the medialization of the fracture, and then you might get a slightly increased failure rate. So if you're doing a sliding hip screw, you should maybe a little more concerned that it is going to break as the fracture heals. So it might determine your choice of implant. Yes. And that's similar to the next question. If the cortex is flimsy or has impending fracture line, maybe it's better to use a nail. I mean, we don't know for sure, but that is suggestion, really. Yes, if you've got this femoral medialization pattern, then to go for the nail, or if you're worried the cortex is going to break, then to go for the nail. Do we use 3D CTs? 3D CTs, they're nice to use, aren't they? But we don't routinely use them because it's not going to alter my choice of implant or technique, really. So we don't, but they're there, and I know some people like to use them. Subtrochanteric fractures to reduce can be tricky. Yes, definitely. Obviously, try and do it on the fracture table first of all with the traction. But if not, then it's got to try and reduce it a bit further with pointers or bone levers to lift it up to correct the sag that might be occurring on the lateral posterior reduction device. But if not, a more formal open reduction and even circulage wires, really, if necessary. So there's no one method for doing it. It's just start off with the simple tri-close reduction and work upwards from there, really. the role of primary arthroplasty I've mentioned, really, it's generally not there. Very rarely do it. You occasionally get a really arthritic hip with a trochanteric fracture. You might want to go straight for a total hip replacement, which is fine. But generally speaking, I wouldn't be using an arthroplasty primary treatment for these, no. And from down here.
Can you hear me now? Oh?
Yes, I can hear you now. Yes, yeah.
Can you hear now?
Yes.
Yeah. So, and I think they have asked some more thing about is there any difference in outcome using IM nail or DHS in pathological fracture? I think you answered it, is it?
If you've got a pathological fracture from tumour, then pretty much always I'd go for a nail and more likely the long nail. So I haven't mentioned what sort of length of the nail we're using. I normally would be using, I think the optimum length of the nail is 200 to 220 millimetres with the locking through the jig. But a lot of them come out at around 180 millimetres, which is a bit short, but it's okay. Ideally, I'd like to use a 220 or 200 millimetre nail for most of these fractures. But the pathological ones, yes, much more likely to nail and put in possibly a long nail for those.
I think one more question is how to control the fracture reduction and to prevent varus collapse.
It's always the fracture table, and once you're on the fracture table, you've got them stable there, then that's okay. One of the tips with the fracture table is make sure that boot to the strap in the foot in is firmly secure, because sometimes you do need to put a lot of traction on some of these fractures to get them reduced to that slight valgus position. And you certainly don't want it slipping during the procedure and losing reduction. So boot on to get the valgus reduction, normally patella pointing to the ceiling, external rotation on the subtrochanteric fractures to control the reduction there. So you shouldn't lose your reduction once you've got them on the fracture table and all reduced. And the vast majority will reduce closed with the fracture table. In terms of weight bearing, I'd weight bear them all. It's regardless. They just all go full weight bearing. No, I don't wait for callus on the X-rays to weight bear them.
I think that's the whole point of doing the surgery, isn't it? To make them to weight bear sooner. Yeah.
Weight bear, yes.
That's the whole point of doing a fixation anyway. So.
Yeah.
And bailout measure for the nail jig mismatch, duty overuse.
Yes. There's a lot more can go wrong with a nail. It is largely experience. So once you've done a few thousand, then it's fairly easy. It doesn't happen. But you've got to do, there's quite a lot of learning in nails, and all sorts of things can go wrong with nails, yes. So that comes with experience, really. So, yes, getting messed with the jig and all sorts can go wrong, yes, yeah.
Question about weight bearing in your practice. I think you start weight bearing sooner, huh? That's what you...
Yes, yeah, we try and sit the patient out the first day from surgery and then progress on from there, really. But it's always... In practice, they don't fully weight bear. They'll weight bear as able because it's too painful. So they have a walking frame and we'll tell them you can put what weight through the leg as they like. And to begin with, they're probably not putting much weight through it. But as it gets less painful, they weight bear more and more and become fully weight bearing. So technically it's weight bearing as able, but we just say you can put as much weight through it as you like. We know they won't in the first few days because it's too painful.
It's a very sensible question. What's your view on entry point in medial edge fracture or subtrochanteric fracture? Is piriform entry better or trochanteric entry better? That's what he's questioning.
No, I always go for the trochanteric entry. On these new nails, it's trochanteric entry. So in the old nails that were completely straight, then it was piriformis fossa. But these new nails with the lateral bend on, it's always from the very tip of the trochanter to go in. So yes, I don't go piriformis at all now, no.
That is because you got that 4-degree valgus in the nail, isn't it? There is an inbuilt 4-degree valgus. Yeah.
Yeah, the valgus bit on the top of the nail, yeah.
But you have for 6 weeks in unstable fractures. If you feel like the fixation is not very good enough, do you make them to keep them on the bed for 6 weeks at any point?
No, they're all mobilized. Yes, yeah.
I think my understanding is like even if somebody is doing straight leg raising, that itself is producing good force on the hip joint. So if somebody is not going to displace by straight leg raising, they will be okay for mobilization also. Yeah.
Yes, that's correct. If you try and measure the forces across the hip,
Yeah.
and you've got someone lying in bed and you get them to do a straight leg raise, the forces are probably higher across that hip due to the muscle pulling across the leg than if you were getting them out weight bearing, partial weight bearing. So partial weight bearing probably does reduce the forces, but bed rest with straight leg raising probably increases your forces around that hip. So if you're worried, partial weight bearing should potentially reduce the forces across it. But I know most of my patients are partial weight bearing anyway because it's too painful in the early days. And then after 2, 3, 4 weeks, as that fracture's healing, consolidating, then they'll start fully weight bearing as such.
I have one question, Martyn. It is about a pediatric, somebody with a 5-year-old coming with a subtrochanteric fracture, or not quite subtrochanteric, like trochanteric going to subtrochanteric. What kind of device you are using for fixation for this one? Not the one, not like tense nail or anything. This is much more proximal to put a tense nail.
Yes, I haven't got much experience on those. I mean, if it's very young, I mean, you probably, what age you say that be thinking of treating conservatively with traction? But again, it's not really my area I've got much experience on.
Okay, fine, yeah. Because the pediatric DHS is also available, which is coming in a smaller length lax screws like that, yeah. I just want to know about your experience. Yeah, thank you.
Yes, no, we have that. I mean, that is one option, yes, but it's not quite my area. Yes, yeah.
Okay, thank you.
Got a question there on the use of bone cement for trochanteric fractures.
Yeah.
I think the general answer at the present time is no. It's being looked at to see if it can make the fixation stronger, either by putting bone cement in at the fracture site to sort of support it, or bone cement around the lag screw to stop it moving. But it's still not proven. It's a bit fiddly to put it in. There's risks of the bone cement going into the joint. So outside the research setting, generally speaking, bone cement on these fractures is not appropriate.
So idea about Cleveland zones is basically there are 9 zones in the head, where center is the central one, and there are 8 zones surrounding it. And you want to focus it around the center in the AP view and inferior center in the lateral view. That's what you want to find out, okay, out of the 2 zones. Yeah.
No, in the AP, it's center to inferior zones on the AP, those 2 zones.
Sorry, correct, yes, correct, yeah.
And lateral, the central zone.
Central center, correct, yeah.
So center on the lateral, yeah. So you've got those, that's the zones you should be looking for, yeah.
Yeah. I think quite a series of questions they have asked. Very nice. Are there any more questions? So we take entry at tip of trochanter for PFNA by action of reaming results in further lateration and results in varus. This is actually, I know, a very practical question that he has asked. This might occur when the fracture line is extending to the trochanter area, greater trochanter area, where your entry point will straight go into the fracture line itself. So is there any tip from your side how to avoid that?
No, it is a potential problem with the nails. And normally the tip of the trochanter is intact. I mean, it may be fractured off, but it's still, by the time you've got the fracture reduced, it's lying there and the tip of the trochanter is intact. You put your guide wire through that and then the reamer through your guide wire to open it up. So, okay, you are in effect smashing up the greater trochanter. That doesn't seem to matter really. And then you just put your nail in. There is a risk as you put the nail in that it sort of opens up the fracture and the femur and the fracture line's opened up and the femur's pushed off laterally. So one could try and just ream a bit more to stop that happening. But generally speaking, it's okay. It all, as you put the nail in and then you start weight bearing them, then that's okay. It does collapse down. But it is one of the problems of putting nails in through it. But they are designed to go through comminuted trochanteric areas. So it's still okay. One shouldn't worry about it. And it's still okay to put the nail in at that.
I think a good awl will really help you to get to the tip. The entry awl should be really nice. That will make you to make sure you get into the tip of the trochanter. Even in a fracture cases where the fracture is extending into the trochanter, still you can manage to get the tip. If you get it, then you should be mostly fine. Yeah.
Yes, you can either use an oil or guide wire. I would tend to say I prefer using a guide wire and then check the positions and put the guide wire in at the very most proximal tip of the great trochanter.
Okay. Oh,
check the position on the AP and lateral, and then put the reamer, cannulated reamer, over the guide wire to open up a gap into that trochanteric area in which you're going to put the nail. And you only need to ream out the proximal 5-6 centimeters with the reamer, enough to get the larger end of the nail in, and then the rest of the nail, I normally just use a 9mm, can go in unreamed.
I think there are no more questions now. It looks like. I think we have taken more time than what we want from you. Thank you. I think there's one more question coming up now. In few cases, after placement of nail, by bringing traction at abduction and able to get valgus reduction and start screws. Okay, he's just giving some comments. Yeah, I agree. Yeah.
Yeah.
Okay.
Yeah.
Thank you, Martyn. I think it was nice having you. And I think you managed to spare some time of your weekend with us. Thank you very much. I think it was a useful meeting. I can see from the participants, there are a lot of quite prominent audience are here. Some professors are there, some senior consultants are there. I can see that. And some of the students are also there. Thank you. And hope it was very useful meeting for everyone. And it was also relayed in OrthoTV, so they can watch over there also. Thank you, Mr. Martyn Barker, for coming to our meeting. And thank you all the audience. And I want to thank all my patients also, because without them we cannot produce all this data, whatever I showed also. Thank all my patients and all my team members. And thank you, Olympic, for organizing this program. Thank you, one and all. Thank you, one and all. Have a good weekend. Thank you.
Yes, sir. Thank you.
It's a pleasure.
Thank you.
Thank you.
Thank you. Thank you very much, sir.
Thank you.
Bye. Bye. Thank you.
Thank you, everyone.
Yes, sir. Thank you. Thank you.